Perfect.
Perfect. Awesome. Thanks.
So I will get started here, Eric, if that's okay. Perfect.
That's perfect. Go ahead.
Um, I would just introduce myself. My name is Vahid Entezari. I am at Cleveland Clinic, and I'm an assistant professor of orthopedics, and I am associate director of the Shoulder and Elbow Fellowship. It's an honor for me to be asked by my great friend Eric Wagner to be part of your lecture series, and I was thinking of like what topic will fit. I grapple with this problem of scapular fractures on a day-to-day basis, and I thought maybe this will be a good topic for us to review. I'll try to keep the talk to around 30 minutes, and maybe at the end we can open it up to some discussions and maybe cases that we can review. Here are my disclosures, and most of them are not relevant to the topic of this talk, but wanted to disclose that I used ChatGPT to create some of the images that are in this talk, and I'll kind of point out those images as we go. One thing I wanted to clarify when we talk about the scapular fractures. What we're not talking about is everything else except the fracture that happens after reverse, because we know things like acromial, fragmentation of the acromion, and fractures in the acromion that can happen before surgery are quite common. You review the x-rays, depending on what paper you read, close to 10, 15% of patients will have something abnormal in the acromion. And as a shoulder surgeon, you get used to looking at these x-rays and CT scan, and you see a lot of these abnormalities. So the fact is, a lot of these are not contraindications for reverse. Like when we see an os, when we see a fracture even before surgery, it gives me personally a pause to kind of say, I'm going to run this by the patient. We'll tell them that, first of all, there is a chance for this fragment to get displaced, but also based on at least two papers that we have, these abnormalities or these pathologies are not necessarily affect the patient's range of motion and patient-reported outcome. They can get displaced and at times painful. So in the past 8 years, I probably had two patients that this became an issue, and I was able to non-operatively manage those. So it's quite safe to first recognize, tell the patient that they might get displaced after reverse, but also, you should not, not indicate a patient for reverse if you come across these problems. How do scapular fractures present? And it's very important because they have some loud presentations. They present as a sudden onset of pain and commonly loss of range of motion, especially overhead 6 months after surgery. Some patients report a history of injury or fall, and that's important because usually kind of brings the focus in some seminal event of I went to physical therapy or I fell downstairs and since then I can't raise my arm. And it's a lot easier to kind of focus and interrogate the x-rays versus a patient that kind of painful since the surgery, but we pay less attention to the presence or possibility of having an acromial stress fracture. And I think that's where the underlying reason for a lot of these fractures get underdiagnosed and commonly missed, and especially in very low demand and less active patients. Rothman Group coined this term of stress reaction, which it's quite important in the symptomatology of these fractures, is that there is some prodromal symptoms that you can have your patients in the form of pain along the spine of the scapula that essentially precede the occurrence of the actual fracture. These patients usually complain about like, achiness in their shoulder. Sometimes patients even haven't touched the back of the shoulder. And as a surgeon, you kind of like, have to include that as part of your physical exam. And you'll be surprised how many of these patients are tender in that area. And as you can see, at least from one study the Rothman group run, uh, when you combine these two, 10% of patients, like, will have some sort of symptoms during their recovery and their scapula related to these problems, which is quite high. When we talk about diagnosis, the first line of business, line of defense is your history and physical. So I think as a surgeon, you have to have a very high index of suspicion and sometimes I catch myself like, a patient comes with a history of revision, and I'm like, thinking about everything else, infection, instability, implant loosening, but somehow this acromial stress fracture or stress reaction slips our mind. And I think it's very important clinically to have a high index of suspicion for these. And especially if the patient reports like they had some prodromal symptoms. As I said, it's important to include this in your physical exam. And your first imaging study is an X-ray. And as you can see in this image, some of them are quite like, significant in terms of like, usually the type threes, but some of them can be subtle as they are more lateral. And you need to kind of review the succession of X-ray to see if the shape of the acromion is changing to pick them up. My second line of imaging study after X-ray, if it's negative, or sometimes if I'm planning to fix these as a CT scan, MRI is usually less helpful because of the scattering effect, but you can do a metal artifact reduction CT and gives you a good idea about how much bone you have and whether or not, like, you can, better classify these fractures. The classification that we commonly use in this setting is a Levy classification. John Levy essentially classified these fractures based on how much of the deltoid they involve, and technically, the larger the fragment that essentially gets displaced with the deltoid, technically you will have more of an impact on the patient's function. That's why the type 3s are worse than type 1s, generally speaking. But this not necessarily correlate with how much symptoms patients have. But in my experience, it has correlation that the patient's function, especially the fracture, if the fracture gets displaced. This is one of my ChatGPT creations, and I kept typing, make her less dramatic, but it was not changing her face, so I ended up using her. But and why scapular fractures matter? So, like, why as a surgeon you need to pay attention to this problem? This is a recent paper, relatively recent, and it's talking about complication of a modern design reverse. One of the things we have to be careful reading literature around reverses, that what era this paper is from, and this is about, like, modern design 500 854 primary RSAs. It seems that we're doing a pretty good job of keeping infections, implant loosening, and instability under control. But as you can see, acromial fractures is the highest, incidence complications after reversal shoulder arthroplasty. There's another observation here is that 22% of patients after reverse have complications. So when you're doing reverse, like, 1 in 5 of your patients will have one way or the other some sort of complications that it should be part of your counseling to the patient, which is like an eye-opening. So not all of them are significant. So it occurs with a very high incidence, but why that is important? Because not only is common, it actually affects patients' outcome. So this is a Franco published this. He was like one of the people that this 2014, now 11 years ago, his first batch of these fractures. And it clearly shows that when these fractures happens, patient-reported outcome, range of motion, and satisfaction gets affected. And it is important because there is nothing else that can this tremendously affect, like, short of like having an acute infection in the shoulder, because most of the complications in shoulder are very silent and they happen slowly. So, okay, so we know it's prevalent, have high incidence, it affect patients' outcome, but what predicts, like, scapular fracture? And I asked ChatGPT to give me my 70 to 80-year-old females that are, osteoporotic looking, and this is the picture ChatGPT created, and that's the patient population that you worry about every time you do reverse. You worry they're going to come 3 months after the surgery and can't raise their arm. I'm going to talk about these risk factors in two broad categories: patient factors and surgical factors. From patient factors, one of the important predictors of scapular fractures is female gender. We don't really know why, whether or not that is association with osteoporosis, if the patient's like, stature and body size and disproportion between the implant size, rigidity, whatever that is, keep repeating in papers. And I'm only quoting or bringing one of the papers that mentions these risk factors, but there's a ton of them that shows female patients invariably at higher risk. This is a 958 RSA's Namdari series that shows like, with odds ratio of 2.4 was the highest predictor of having scapular fracture, acromial stress fracture and reaction. The second patient factor is osteoporosis. It's kind of intuitive that when the patient's bone quality is not good, you can have stress fractures, but this is the second most cited in terms of patient factors and predictors of chromial stress fracture. This goes back to another series by Frankel that showed osteoporosis increase almost like the odds of a stress fracture two times, and specifically for scapula fractures, which tend to be more medial. Some of those initiated from the screws that we're going to talk about, like later in as surgical factors. Um, I think one of the interesting events that happened in the past 5 years in the area of reverse research is creation of multi-center studies that allowed us to study some of these big questions that we have about the reverse with a lot more, power. This is a RSA complication of RSA research group that's run by Andy Java, which has produced a lot of multi-center studies. And As you can see, one of the predictors of scapular fracture ends up being, deficiency in the cuff. So patients who have diagnosis of cuff tear arthropathy, irreparable rotator cuff tear, and rheumatoid arthritis tend to be at higher increased risk of scapular fractures. They break it down to acromial stress fractures and scapular stress fractures, and it seems for both of them, cuff tear arthropathy, inflammatory arthritis, and in deficiency in the rotator cuff becomes predictors. So when you think about why this is the case, I know when the rotator cuff is gone, reverses will have worse, patient satisfaction and function. But maybe, this paper will give a little bit of a clue as maybe why this is the case. This is a JBJS publication from the HSS group that they hypothesized that maybe the incompetency of the CA ligament plays a role here. As you can see, the forces are applied that are applied to the acromion as the insertion point of the deltoid. Almost gets this, neutralized when you have a circular structure connecting the acromion through the CA ligament to the coracoid. And when we have multiple surgeries, prior rotator cuff surgery, or in cases of cuff tear arthropathy, you can have attrition of the CA ligament. And now you have an unopposed, force applied to the acromion by the deltoid. That might be the reason, this trampoline effect that causes the, fractures to occur. One of the most recent, risk factors that papers are talking about is maybe the shape and, structure of the acromion itself. There are at least two papers that talk about like acromions that are more thinner and lateral, half of the acromion, and their shape is more posteriorly directed. Maybe those acromions are at increased risk of fracture. And this is another paper that essentially classified the shape of the acromion and associated type 1, 2, and 5 with higher incidence of acromial and scapular spine fractures. So this might be also plays into, the risk factor. So the last patient factor that I'm going to focus on is the injury, postoperative injury, which I tend to quote as like the mother of all evils after reverse shoulder replacement. When you think about instability, when you think about acromial stress fracture, periprosthetic fractures, in this patient population comes from fall. And I think we underestimate how many times our patients fall or fall prone, and maybe we need better ways of assessing our patients like fall propensity. So Julie Bishop and Ohio State group looked at this, and 10% of their patients at the first 90 day after surgery had a major fall, and at least one paper links having an injury with the scapular fractures in this setting. When we look at the surgical factors, the first time that we actually focused on this was maybe the association of the base plate screws with the as a stress riser for the acromial stress fracture. So Crosby was the first person that actually wrote this in a paper that in their series, all the type 3 fractures were associated with a stress riser from the posterior superior screw. And Frankel's group, as I said, as I mentioned earlier, in their group, 14 of the 16 scapular spine fractures had a stress riser from a screw. And Howard Rothman and Exactech group showed that when they increased the number of screws they put in the base plate, those patients were at increased risk of uh, uh, fractures, scapular fractures. And when Crosby's group actually went back and stopped putting the posterior superior screws in their base plate, they showed that they were able to reduce the rate of their scapular spine fractures. So that's one thing that I personally, when I'm putting the posterior screws in the base plate, I'm very careful not go in, out, in, and also tend to actually not put screws in the posterior superior quadrant if there's good fixation by the other screws. This is one of the surgical factors that probably there's good data around it that maybe may lead to the larger type 3 scapular fractures. How about humeral distalization? When we started kind of facing initially with the scapular fractures after reverse, most of the reverses were Gramonta style. A lot of them lengthened the arm significantly. And that was the thought is that by pulling the arm down, we're adding, essentially creating a lot of stress at the insertion point of the deltoid, and that's why the acromion breaks. There is some, supporting literature around this topic. Larry Cullotta did a cadaveric study and showed that when they lengthened the arm more than 25 millimeter, they started seeing a concentration of a stress over the acromion and scapular spine. And when two papers looked around this topic, one there was a group that switched to from an inlay reverse design to an unlay, which technically creates a lot more humeral lengthening. In their series of 485, which was almost like half and half, they saw that the rate of acromial stress fracture went up. So that's like by you can infer that by creating more humeral lengthening, you can create acromial stress fracture. And also in Chow et al. Wrote this paper on 787 patients, and this is the only study that actually the arm lengthening ended up being with not very high odds ratio, but statistical significance predict acromial stress fracture. So then we can conclude that maybe a humeral lengthening is one of the factors that can lead to the acromial stress fracture. So the third, surgical factor is the glenoid lateralization, which is less intuitive. And when we initially kind of transitioned from a Gramonta style to a more modern design, reverse total shoulder arthroplasty, the group that was pioneer was Jonathan Levy and Frankel's group, and Jonathan Levy has been very, honest about reporting his scapular fractures, and he reported in his first initial series of reverse shoulder replacement by highly lateralized design, up to 10% of acromial stress fracture, which is the highest reported in the literature. So there is this thought that this study by George Atwell is trying to kind of get at is that through a cadaveric study showed that when you start lateralizing the glenoid purely through create lateralization purely through the glenoid, there will be a concentration of force in the zone 2 of the acromion. And maybe, when the lateralization gets between 6 to 10 millimeter, this gets to a critical, level that, probably problematic. When you look at the, other studies that are clinically looking at this, there's a much larger clinical study that look at that, which is part of the complication of RSA group that also looked at this, and that study is actually more conclusive. Is that pure lateralization through the glenoid is predictive of the acromial stress fracture, and actually lateralization through the humerus may be protective. So, this is the by far the best evidence we have regarding glenoid lateralization in this setting. Uh, Superior impingement is very interesting. There's more papers that are like, focusing on this. This is Jonathan Levy's idea is that not only we create a chromial stress fracture by pulling the arm down, but if we don't, inferiorize the base plate and not create enough space over the, glenosphere by impingement of the greater tuberosity over the acromion, we can create acromial stress fractures. This is at least one of the studies that show that with more retroversion in the humerus and also superior migration of the base plate, you create superior impingement. And when you plan our cases like use softwares that like Blueprint that you can actually simulate the range of motion, you see that how many times your implant or the greater tuberosity has a chance of touching the acromion, which it makes this motive acromial stress fracture plausible. So when we just put it all together, reviewing the literature, here is what we know about the risk factors of the acromion. From a patient's factor, female sex, osteoporosis, primary diagnosis that associates the patient with the cuff deficiency, acromial morphology, that if the acromion is thin in certain areas, and especially post-op injury and fall, makes patients prone to develop acromial and scapular fractures. From a surgical factor, superior base plate screws, humeral distalization, glenoid lateralization, humeral lateralization, which will be protective, and superior impingement are the risk factors surgically that can cause acromial stress fracture. So when we say how to prevent a scapular fracture, again, I asked the chat GPT to give me a picture of same set of patients, but they're younger. It would be really nice if we had to do reverse in a much younger patient population. We would not have probably this problem, but obviously that's a joke. We can't really change the age of the patients. So then it goes back to this idea of what else we can, change, or what can we do to prevent stress fractures. And it goes back to this idea of patient selection. When we look at these papers and talk about these risk factors, it's very important to know that these risk factors are independent, meaning that when you're doing a reverse in a female patient that's osteoporotic and have a cuff tear arthropathy, your risk of a stress fracture is now not 4% or 5%, it's 20%. So they accumulate, and that's not an uncommon patient for to get the reverse shoulder replacement. That's why I think this discussion needs to happen that this complication is actually not uncommon, and you have to talk about it with the patient. One thing I have changed in my practice is that I'm more scrutinizing patients for risk of fall, sending them to physical therapy, formally assessing their fall risk, and see if they can, have an assistive device or something that they can actually change their home situation. And lastly, when from patient factors, it's very important to consider hemiarthroplasty as an option because nowadays we do a lot of reverses in cuff intact patients. And if the patient is in that category, considering hemiarthroplasty is still an option, which we usually kind of not give it a good, thought. From a surgical standpoint, can I do my reverse shoulder replacement in a way that I prevent these fractures? I think by not putting the screws in the base plate, avoiding excessive lateralization. Again, I can't really, pinpoint based on the literature a set number, but it seems the number that are like, if you get higher and closer to 10 millimeter, you're probably at the danger zone. So, I personally try in terms of lateralization to stay at or within a 6 millimeter of lateralization. Distalization is another factor that I try to control for my female patients. I try to stay around 25, and for my male patients around 30. These numbers, again, like, changes with the patient's body habitus. Obviously, a very large, like male, like maybe you can go to 35. And I think if possible, avoiding the unleaded designs to, essentially over distalizes the humerus and paying attention to superior impingement because this is something that we don't necessarily pay attention. Bringing the base plate lower on the face of the glenoid is important. And also, we tend to not think about like when we put larger glenospheres or larger polys about what that it does in reducing actually the space over the implant. So we tend to kind of think about lateralization and distalization, but I think by putting bigger polys and also larger glenosphere, you actually reduce the space available for the range of motion superiorly. And I think this is another change in the recent years for me is that I put the patient's arm through a full range of motion, including abduction and range of internal external rotation in 90-degree. And it's amazing how many patients that you wouldn't think they will have a, greater tuberosity scratching their acromion, but that happens a lot more often than what we think. And I think that's another mode that we can avoid by, thinking about it and essentially planning accordingly. Um, how to treat the scapular fractures? Obviously, would not with body cast, but uh, this is like a little bit of background is necessary here. I think with our poor techniques of fixation, our initial reaction to these fractures when we find them, I vividly remember with Dr. Ainati going through a series of these patients and initial experience of reverse and trying to fix all of them. And invariably, all of them failed, like, through plate breakage, loosening of the screws. And it kind of created this reaction of maybe we should not treat these fractures with surgery and we just like, non-op all of them. So that was like the initial reaction because we didn't really know what to do with them, and also the results of the surgery were not great. So this is study actually, it's a meta-analysis looking at all the papers and in 2023. And what they did essentially showed that patients who were non-operatively managed after an acromial stress fracture had really poor, outcome. There's like 340 patients, and they compared them with 3,000 controls and showed that these patients had inferior function, satisfaction, and range of motion across the board. And it kind of shows that probably what we're currently doing, for these fractures, is not great. When we talk about what to do with these fractures, maybe we need better ways of delineating who does well and who doesn't well with the non-operative treatment. This is a recent paper by John Levy in 2020, not so recent anymore, 2022, that essentially they took 44 of the fractures and matched them with 180 controls, and he showed that actually maybe in the zone 2 we need a better classification because when he saw that the fracture is lateral to the face of the glenoid, which some of the zone 2s are like lie in that area, they actually did fine with non-operative treatment. And when the fracture was more medial in the zone 2 and 3, the patients actually didn't do well with the non-operative treatment. So he came up with this sub-classification of twos and dividing them to two A's, two B's, and two C's, and essentially put the two A's with the type 1 and two B and C's with the type 3s, and kind of created this dichotomy and maybe more lateral ones that are at the lateral to the face of the glenoid can be safely treated non-operatively. And I know I've had conversations with him, and he actually now doesn't keep these people in the sling anymore. Like when these fractures happen, he's more aggressive in getting them to move. Which I'm not sure. I'll show a case that probably that prop can lead to more displacement. I'm not sure that actually solved the problem, but maybe his inclination of maybe we need to do something more besides the non-operative treatment for the more medial fractures is well founded. Another development is that how we used to fix these fractures. I have a series of like 15 of them that we're trying to publish is that they all were fixed with non-locking, a single plate with some, combination of suture and wires. And I think when you look at the constructs, you realize why these didn't work because they weren't neutralizing the fracture. The bone is very poor in this area. It came from not having a quite understanding of how these fractures actually, are loaded after fixation. So I think there's at least two papers that shows that probably we need more than one play, maybe 90-90 to be able to neutralize the rotational forces across the acromion, and probably we need some form of uh, locked plating so that you can control in the poor bone the fracture fragments better. This is the paper that I think kind of shows maybe the acute ORIF will be the way to treat these fractures going forward. John Levy and George Athwal published a series of patients, about 74 RSAs that had type 2 and 3, and they essentially divided them between surgically treated and non-operatively treated. And I think there was a time frame that they decided to treat them surgically. That's how they divided them. And the ones that were within 6 weeks of recurrence of the fracture were surgically fixed. As you can see here, had better subjective shoulder score, ASCS, forward elevation, and they had higher union. And I think that's kind of matches with my experience that now that I'm more aggressive and if the large acromial stress fracture happens, I'm more convincing the patient that this needs to be fixed. I think I see better healing rate and the patients might be doing slightly better, but not still excellent. I'll finish this talk by kind of going over maybe three cases. The last case will be a little bit of the technique. The first case is I thought I'll bring up this case because it shows that you can kind of have this neglect, or I wanted to say benign neglect, but this case shows that that neglect is not that benign. Is that I had a 92-year-old patient. She went through this whole long period of non-operative treatment. Initially, she was adamant about have surgery. She's like, I'm going to use injections and physical therapy, but eventually was forced to actually, because of her symptoms, to have surgery. She was clearly had a cuff arthropathy and very poor function. So I really nowadays consider Hemi in these older patients if I can. But the function was important for her. And when you look at how I distalized her, probably you can, um, there might be a criticism here is that I probably distalized for more than 25 in this case, and that's might be the reason this happened. But her fracture was associated with a fall. She had slipped and fell at home and had this type 2 acromial fracture. So I had a conversation with her at that time is that I think this is a big piece. It's kind of displaced. We should do something. But she was like more focused on other health related stuff that, she ended up, foregoing the surgery. And as you can see, this piece was completely displaced and was actually healed downward. And I think she started actually developing this notching. Um, of the poly because her scapula kept like trying to go and her tuberosity was showing some signs of osteolysis as well. So as you can see in the final follow-up, it's about like a year or so. Initially she was adamant not wanting to have anything done, but then after a year she was like really wanted to go back, and my response was like, I have to break this again and rearrange it, and it's like madness. I'm not doing this. But her function was really poor because this was like essentially physically blocking her motion here. So that kind of tells you that maybe just ignoring these fractures sometimes is not that benign. And I'm going to show you a revision case. This is a patient, 76-year-old, who had a right RSA 5 years ago, came and had this kind of indolent infection brewing there and leading to base plate failure. We went through a two-stage revision. As you can see, he had this uncontained, really bad glenoid bone loss, and I ended up doing a VRS. And I mean, Eric has some experience, experience with VRSs. Is like, they tend to kind of solve the problem of pain, but then as you can see, it kind of lengthens the arm significantly. For him, he actually did really well for a year, and his fracture happened like a year and a half after surgery, and you can see it's actually a type 3 extending all the way back, maybe initiating from one of the screws, but this was around the same time that the papers were coming that we should be more aggressive. And I talked to him, and he's like, "Yeah, we'll get it fixed." And we actually got to it maybe 4 weeks after the fracture happened. I double plated it. And I have like, a CT scan a year after that his fracture completely healed. And he came for a year follow-up, and he's like, 140, 130. But these patients don't get their overhead function if you don't operate on them, especially if the scapular spine is like, the fracture is that big. And I'll quickly go over this last case, which is kind of iterating the same idea that we should be getting more aggressive with these fractures. This is a patient that fell and had a periprosthetic humeral fracture and an acromial fracture. And, I'm through conscious because he had good function before surgery, couldn't ignore either of them. So I ended up like, fixing both. This is how I go through. I try to kind of go through the fracture site. One thing I try to do is that if it's possible, not put the fracture where it was, because I feel like if you put the fracture back where the fracture happened, you're creating the same amount of forces across the fracture, and that's like, ought to fail. Another thing that I think it's important, in my opinion, is that distal piece is actually very soft and tend to not hold screws really well. As you can see, I very similar to proximal humerus. So I try to put these set of sutures at the deltoid insertion and use those sutures to neutralize the pull of the deltoid by sewing them to the plate that we'll use later. So I try to create like good contact between the bone, compress it, put K wires through it, and that's the time zero fixation. And after that happened, then I try to put my plate on. I use the contralateral lateral clavicle plate. This is like an Artrex plate. I have no conflict with them. But what I like about these clavicle plates is that they have holes in them and allows those sutures to pass through the plate. And here, we did a little bit of bending. You will see in the X-ray is that I put the double plate. The plate from the back is going like, P to A, and then the other plate is on the top. And I try to use the sutures, put the sutures to the plate, and also do a tension band suture in a knee knot fashion. on top in a figure of eight fashion that again pulls the piece back to the plate because a lot of times like you get the fracture fixed, but then like later on, 4 weeks later, that distal piece pulls off of the plate, which I've seen that happen. So these suture, management is trying to essentially neutralize the pull of the deltoid on that piece. This patient actually went on to I protected him for a few weeks and then started moving, and this is like year follow-up that he healed his humeral shaft fracture with a huge callus, but his acromion, as you can see, healed. So my hope was to kind of maybe review literature, thought process, and kind of what we should be doing. And I'll be happy to kind of open this to discussion. Sorry, I went a little bit longer than I was expecting, but happy to kind of hear what you guys like, how you've been essentially dealing with this problem.
Vahid, that was fantastic. So, those of you who are on, I think many of you have heard me talk about Vahid, but as you can see, he's not only is he a really talented surgeon, but super, super bright, very fair, and that was one of the best overviews of a super complex topic that we're still learning a lot about. So that's awesome. Congratulations, man. That's really, really awesome. I wouldn't expect anything less from you. Yeah, so if it's okay with you, I would love to open up to some topics. He's actually, just so you know, Vahid, you followed John Sperling last Monday, and definitely there's different viewpoints being expressed. So I love it that your talk couldn't be more timely in that respect. And then, but I'm going to open it up to some of the trainees and some of the other faculty, and then we'll probably on stuff. So anybody have anything they want to ask Dr. Intezar?
Well, I think you kind of mentioned it during your talk. I guess my question is for those people that have such bad cuff tear arthropathy that they've already started to erode through their acromion. It sounds like from, I'm assuming, a pain standpoint, are you just doing a hemi, or are you saying, like, look, we'll do the reverse. If it fractures, we'll do something?
I try to kind of gauge if the patient is a patient that if the acromial stress fracture happens, they're going to care about their function, or they're going to reverse to have like, a pain as a pain relief surgery. So um, the patient that is kind of get really bummed by these fractures is the patient that went through the reverse to get improvement in their function. And this happens, and it's just kind of it's a devastating complication. So a lot of the really elderly patient, I try to kind of do the reverse, kind of do the some of the modifications that I just said. If I'm like, the goal is just pain relief, not put them as tight. And Eric, are you trying to say something like you're muted?
Wags, are you talking to us or someone else? Eric?
Eric, sorry, I didn't want to like miss if you wanted to make a comment, but point being,
No, you're good. You're good.
yeah, yeah, perfect. So point being, you know, I can't claim that I have figured this out, but I try to kind of hone in and, you know, I think we need better risk, predictors. Like that's the first thing I'm trying to kind of create. We went through like our cohort of patients, and we have like a risk calculator that we use like in a rudimentary fashion. I'm trying to kind of create an online version of that, at least like to give the surgical conversation a little bit of like perspective of like, hey, your risk is 17%, your risk is 20%, like,
Have you
and
have you prophylactically have you prophylactically plated someone prior to surgery? I mean, I personally have not. I don't know if Wags has. I don't think he has. I'd have to ask him, but I don't. Not that I'm aware of. But I mean, I personally have a hard time doing that. Obviously,
yeah, I mean, like there are these like challenging cases. Eric Ricchetti had a case that had a largely displaced acromial stress fracture type 3 preoperatively, and the patients have cuff arthropathy, and he's like, what do I do? I do plate this, do the reverse, like, or plate and do nothing. So I mean, this problem can presents itself like, in a variety of like, fashions. I would say Acromion is such a, weird area that unless we come up with like plates that are fracture specific, fits to the bone, and we know that our fixation works, then I can kind of convince my patients to have a prophylactic surgery. But just like a surgery that I'm not even convinced that works, like, my hand, I haven't perfected its technique. Doing it prophylactically is, as to me, it's experimenting on patients. But good question. I mean, like, it's like every time I'm like booking a 90, 80, 75-year-old osteoporotic patient, for reverse, I'm thinking about this, talking about this with the patient. The question I would put to you and Eric is that, are you guys doing your reverses any different in a cuff intact versus a cuff deficient patient? And, people talk about like maybe not putting the cuff deficient patients too tight, but then like you worry about their instability. So it's just like a little bit of a um, you know, challenging proposition to say I'll change the way I do my reverse. You want to do reverse, first of all, not to dislocate, to have like, decent range of motion and all of that. So I think it's challenging. You can kind of solve one problem and create another problem by necessarily, changing
Yeah.
what you.
Yeah, Vahid, I was going to push you a little bit on that. So, you had like this great summary and lots of awesome data. But one of the things I hear from my trainees, which I think is very astute, is it feels like everything that we recommend, it causes another issue, right? Like you don't distalize as much, but then you and inlay, but then maybe you have instability. Or like don't distalize, but also don't impinge on their chromium. So if you're not distalizing, but then how are you not going to impinge? Or like, do inlay, but like, but don't make it so unstable so what do you tell your trainees when I feel like we have lots of great recommendations on what people prefer what people to do, but then a lot of it's contradictory, whether it's preventing chromium fracture, like you mentioned, there's some contradictory stuff in there, and whether it's, solving one problem to create another.
You know, you hit the nail on the head. It's like uh sometimes like have sessions of planning with my fellows and they're like, oh, like why you're doing this? I was like, because this patient, I've met them and I think like, this is like a poster child for acromial stress fracture and they're like, but like, we had another patient the same age, like, we didn't do this. So to your point, we don't we're not treating this problem systematically, and I at times feel that we do anatomic, for instance. I'll go back to your question. There is like a reference for anatomic toe shoulder arthroplasty and recreating the anatomy. So, everything in terms of where the implant ends up, like, is this joint overstuffed, not overstuffed, balance and all of that goes back to a reference, anatomy, which is anatomy. In reverse shoulder replacement, we admit that our mode is avoiding complications. So like, we're doing reverse, and if it doesn't dislocate, it doesn't have an acromial stress fracture, it doesn't get infection as if like that's the best surgery. But then, we're doing reverse as the primary in patients that are commonly like the same age as anatomic patients. And our mode of like thinking is that, I'm going to do a, I'm going to sell you a car that doesn't crash, doesn't go into the wall, doesn't like, it's like it's a really the way we think about it is like wrong. And it's an underlying philosophy that we have in reverse. And I think we need to move beyond that. The challenge we have is that, okay, we don't have the reference, which is the anatomy. And then the things that we're talking about is so personalized, like the distalization. Is the distalization for a 6'4" male is the same as a distalization in millimeter measured for a 5'1", osteoporotic female? Of course not. But we just kind of like, talk in, absolutes, like, millimeters, numbers. So I think we need to come up with, and machine learning, like way back when I was thinking about like planning, I thought like, we should say, okay, impingement free range of motion is goal of, reverse shoulder replacement. Maybe humeral component like has less variation. We'll kind of have the person put their humeral component in, and then we'll have them pick the right like base plate and say based on the size of the patient, pick a size of the glenosphere, but then have the software run the shoulder, a simulation, and then give you a globe of where you can put the base plate that gives you the best impingement free range of motion. That might be like, this big area. Then you can start honing in and saying, okay, in within this area, now I can distalize this much, lateralize this much, and then kind of start like I think it's such a hierarchical, multifactorial things that our, human brain that only can think about one, maybe two, maximum three things at the same time, is not going to be able to solve. And I think eventually it's going to come into, defining some parameters and having some sort of like software telling us like this is the ideal area. And to your point, maybe kind of connecting this to some sort of like data, maybe robotics will do that because with, the advent of robots, like the only byproduct of that is that you know where the implant ended up. So robots is going to prepare the glenoid. That's where hip and knee guys are, is that, their implant related factors didn't get really kind of tied into the pay to the outcome till they started doing, surgery with robot, and now they know where the implant ends up. And now you can tie, these factors like implant factors and patient factors to the outcome. So I think we're a little bit behind that, and there's a lot of kind of um, maybe groundwork needs to happen because to me, I don't see us going and doing like 1,000 patient like CTing their shoulder, finding out where this implant ended up, and doing a multi-center study with CT scan ever. Like who's going to fund that study? So I think like there's some changes in the way we practice surgery is going to come down the pipe that eventually makes us more precise in terms of implant placement and hopefully provide us, in the feedback back loops like more data driven, surgery.
Yeah, no, that's great. Those are all great points. I mean, you AI, without question, I would agree that the AI is going to be really, really important to help us with this. It's the world. And you mentioned hip and knee. I mean, those are anatomic arthropod. Those are anatomic procedures, right? We're talking about a non-anatomic procedure here. So it's like, it's like a whole another realm of things. And then we don't even bring up, the idea of intraoperative tension and soft tissue, all that stuff. So it's just like so much to this conjoint anterior shoulder frame, and there's so much to this that we are working. We solved notching by lateralizing almost, not totally, but almost solved notching. But man, it's the world of other issues have popped up. And it's so funny, you hear all these, I have a lot of a lot of people are saying, oh, just do reverse, just do reverse, just reverse. Like, look at the Australian data, look at some of the other databases that show the survivorship rate. I was like, yeah, but I mean, look at the complication profile. The complication profile is still much higher for reverses, and those
Yeah.
complications are just devastating. And then look
Oh
at the
my.
revision profile. I'm like, oh man. So it's fascinating. It's fortunately, I think we're getting data, like you said, getting robot data, getting hopefully some other really high quality data that can help derive some of this stuff. But I think we're still so much in our infancy. So no, I completely agree with you.
So John Barlow was talking about the scapular fractures as well.
Sorry, what'd you say?
You said Jonathan Barlow was actually talking to you guys about the scapular fracture as well.
No, no, no. John Sperling, not scapular fractures.
Early,
He just talked to us about shoulder replacements and the
I
evolution.
see.
But part of it was on what you were just talking about on like their inlay versus onlay and some of the other stuff through the Mayo data, and obviously it's just a different I don't know. It's recorded, so I'm not sure what I should say, but it's interesting because it's there's a lot of so here I take this. So when you look at the big data sets, Vahid, and I think this is fascinating, and it's hard to explain this to the trainees, but when you look at the big data sets, you have the Mayo data set that has lots of great studies coming out of it, right? You have the Australian data sets that's coming out. And then you also have like we have friends that have published a lot through the VIP, Arthrex, through the
Exact.
Exactech
Yeah.
registry, through the some of these other stuff. And man, it's like so wild. The differences when you look at these large data set publications, right? Like there's ones that say bone grafting is great. There's ones that say bone grafting fails in everybody. There's ones that saying inlay is great. So there's one that says onlay is the way to go. I mean, it's just like it's kind of funny and kind of wild and also kind of hard to interpret if you're really trying to like bear it all down. And of course, all of us have our biases, so all of us listen to like what we want to listen to. But it's like it's funny because it's like the yeah. Anyways, it's fascinating, and I can see why it's so confusing for people because there is a lot of conflicting data
But
out there, and it's hard to boil it
Eric,
down.
you're
You
saying
do a
that
really nice
for
job of boiling down on this specific problem, but it is hard to boil it all down
But,
with
but
all the
Wags, I think
different.
part of that is just because, as we know, right, is perfect example is so many of the systems have so many different morphologies of the glenosphere, the poly itself, the poly thickness, retentive versus not retentive,
Mhm.
whether it's truly inlay or onlay or all the various things that go with it. Whether it's more of a distalization versus a lateralization type of implant and all this stuff. So yeah, obviously, like it's very hard. And I'm not sure how generalizable some of the results are for some of the studies, unless you're using the same implant systems of things that they were comparing to. I
Yeah.
can tell you, Wags and I have looked at our own data set, and we had a lot more acromial fractures when we were using the Ascend Flex stem versus the Perform stem. A lot more from a true same stem system inlay versus onlay. That may not be true if you compare, let's say, some other stem to what we had, but at least I think, Wags, you can say from going from a Tournier Ascend Flex stem to a Perform stem, our number of acromial fractures have gone a lot less. Granted, early on we had more dislocations, but we didn't realize that the poly thickness had changed dramatically from retentive to not retentive, relative to other companies that we had used previously. So I think internally we've used our own data set to guide our principles, but Wags, you may argue with me on that. I think we've looked back really good at our data set to guide what we do.
Yeah, I mean, I have gone through that process. Like I was trained with DJO and I switched to using Ascend-Flex. And then from Ascend-Flex went to Perform and I had the exact same, I was making my same humeral cuts and you don't realize that you don't get you get very minimal lateralization through that stem, and you can't really afford making aggressive humeral cuts. And also, to your point, the poly was like very shallow. Now the 55%
Yeah, so I was
cap.
very similar. I started off using DJO, and the DJO retentive poly is actually still deeper than the
Yeah,
retentive Perform.
yeah, yeah. Their standard poly is like 57% capture. So actually DJO and Artrex are the highest like capture ratio in the market, which kind of to your point, it's such a multifactorial thing, and when you go from one design to another, it's very important to do incremental changes because when you change more than one or two things, you don't know the combination of them where they're going to take you. And just you know, part of it also comes from like our knowledge of not knowing what's important and what's not. Like this poly capture ratio was almost like an undiscussed, undisclosed, like, information that every company was doing its own thing till like, likes of Loop Marauder and like this discussions like putting some like data behind it is like guys like we can't really look at instability across different implant system where this capture rate is like so different, and so you keep talking about lateralization, why the problem is the poly or
Well,
the
so we had the same discussion. So I actually called John Levy personally. I had like an hour-long Zoom session with him when DJO went from their large shell to a small shell, and it was much better for all the females out there because of their
yeah.
stuff. I had a whole discussion. I was like, something's not fitting right. This doesn't feel right. He's like, oh yeah, it's the poly issue. We've kind of noticed that. It's just not like a very well recognizable thing that we haven't gotten out into the literature yet. And I was like, well, those are the things you don't know until you've put in a few of them, and then they come back and they're like, okay, there's a difference on this. And I think that's where I tell everybody, if you use the system, it's not so easy just to flip back and forth between four
100%.
systems. You get very accustomed to what you're used to putting in, the tension and how you do it. And no one really ever talks about the learning curve for a various system, right? So like if I said, hey, Wags is going to now switch to some other system he's never used, I'd be curious how many actual reverses it takes to get you back to where you were before with the system that you're comfortable with.
Yeah, I mean, there's a huge learning curve with that. Yeah, yeah, it's interesting. Yeah, it's interesting. But you and Gotchak really had the same sort of evolution. But I mean, without question, we're finally coming out with our data on inlay versus onlay, and it's striking. But it's fortunately it's like three systems. It's DGO, it's Striker with Simplex and Striker Perform. And the obviously DGO and Striker, the new DGO and the Striker Perform, are actually inlays. We kind of came up with this like hybrid because there's like plenty of the old DGOs that were put in but weren't really actually inlays. But it's striking, at least in our hands, like the difference between 135 inlay and 145 onlay from a chromial fracture standpoint. Now we did have the dislocations initially, but it seems to be improved. But it was shocking to both of us because if you look at it, we neither of us had a dislocation for like 3 or 4 years, and then we switched to perform, and
It was the
six
exact
months
same
we
thing.
each had like two
Five
or three,
years
and we were
without,
like, yeah, and we're like,
yeah.
what the fuck is going on here? Like, this is not something that we've had to deal with. And then I don't know, but I am an inlay believer because of the chromial fracture decrease that we've seen. And I'm a huge, I don't know, I've become a huge believer in that. And then trying to tension it right, I think has also been helping. But um, yeah, I don't know, man. It's so funny. Yeah. Anyways, it's so many different philosophies out there about replacements. It's interesting. So.
To my point is not necessarily even like, the perform issues. Like I was talking to Eric, I was the same thing. Like, 4.5 years, like, zero dislocation. And then I switched to perform. I had like four dislocations in a matter of 6 months. And I went to Eric and I was like, Eric, I don't know what I'm doing wrong. Like, I switched my system. I feel like every surgery I do, like I'm not safe. And so, Eric said, don't worry about it. It will just like, you figure it out because I switched from Grammont to DJO and I had four dislocations in the first 6 months. I was like, how's that? Because to your point, you almost lose your reference point. You start kind of like, have to build that confidence back up. And it's a lesson and also like how technology gets introduced in our field is that, you hear, oh, the company you're working has a new implant, and then ref knows very little about it. And I think brings up Mike, your point of saying maybe I should have actually take time to go and spend my key maybe a day or two with someone that actually had used this implant for like, 6 months more than me. And I probably would have like, had less dislocations. I don't know, but there's just this sense of like, hey, this new shiny thing that I came up with here, try it. And then we're kind of like, in orthopedics, we're like, yeah, I'm just gonna.
Even worse than that, when we introduced that new stem, we had somebody come out. I'm not gonna mention who, but we had somebody come out, and we were told by both our rep and this person that like when you impact the stem, you had to put the poly on the back table, and then you impact the stem. And so all of our stems were ending up in varus, and we were like, how the hell are they supposed to like? Why is this like you have no control over this? And then eventually like we learned, yeah, 6 months, a year later, oh, well, you can actually like impact it not with the polyon. You can put it and then put the polyon once it's impacted, and you can control the varus valgus much better that way. But that was like once again like something we had been told by somebody who supposedly was like one of the people who kind of helped promote this, and one of the surgeons who had like done some and helped promote this, and by the rep, and it was like not right, and it definitely like
So I will
impacted
tell you two
our.
things. So one, it's like every time something changes, it's like you have to refigure it out. So one thing is we started, as you know, and Wags kind of got me on this, and I think for some reason I think the software did too. I'm going to say that even though it's recorded. Magically, everyone needs an augment now, right? Somehow or another, before I used to plane it, I'm like, I can get away with the standard base plate. Now, everyone almost magically, you put in an augment and it gets it back to perfect stuff. And you almost have to read nothing off the glenoid, right? Minimal wear for something like that. And so, like, now it's like, okay, we're lateralizing more off the base plate with this angle, with essentially some sort of stem, fixed slightly down. And then lateralizing off the glenosphere is actually off-label use, right? So you have a lateral, I mean, Wax knows this, but essentially if you put in a full wedge perform base plate and then lateralize off of a 42 plus whatever, that's technically not on label use.
Yeah, you
Well, I'm
can't
assuming you
put
know
in
that,
any
but
lateralized glenosphere on a full wedge. Yeah.
yeah, but I mean, we do it all the time. I mean, I do now. I mean, I do it on my big males. We do it almost all the time because we have a little device that you put in and you're like, hey, how tight are they?
Yeah,
We have like a little space for like gap
yeah,
balancing
but
type of
we
thing.
started this thing called gap balancing. We're just starting to look it up, but it's we basically took the Mako paddles for the
Mm.
knee and use them to try to measure the gap when you put in the base plate. You put in the base plate, and then you had the inlay cut surface, and we've been trying to gap balance the difference between the base plate and the cut surface, and then matching the glandular lateralization based off of that gap, which
It's a
you
good
can't really
idea.
do an onlay. That's the nice thing about inlay, at least in my mind, is doing something like that to hopefully get some sense of like soft tissue tension, which is, I don't know, gut check for me, it's actually made me lateralize less. Maybe it sounds like it's made you lateralize more, so maybe
I
we're back
lateralize
to
a
where
ton.
we
I lateralize
were
a ton more often
before,
because I'm
but
like, oh, if I can get it in, I'm going to put it in. But I will say it's the same thing now. So it's like that I have to still figure out to some degree, although I feel like I've gotten pretty good. But I'm always worried about it. I'm like, I don't want to get a acromial fracture, so then I back off a little bit. And then like now I've had two people that have had to, I essentially didn't put in a retentive poly as of 6 to 9 months ago. So it's like I have to literally go back, put in a slightly, I've lateralized them literally as much as I possibly could on the lateral side. And these are large nails with cuff tear arthropathy that have still managed to do something. So I've had two recently, but then the third one that I just did last week that I don't know, I'm still the stuff's out. I had two small females that I was essentially putting in a fracture reverse for people that had super complex fractures that were like 4 months out that couldn't come in because they had seizure disorders, posterior, the
Mhm.
head sitting back behind the scapula for 4 months. And I decided to put in the perform reverse for fracture, and that is completely different stem than the Aqualis for fracture. Like not even like remotely night and day. And I'm very worried about instability, even though I've cabled all the tuberosities around and got it. I meant to ask you, Wags, whether or not you're lateralizing more or putting in a retentive poly even in your reverse for fractures with that stem.
are you asking me? I mean,
Yeah, no, I'm saying it's one of
remember
those
I
things.
told you I wanted to do that study, gut check. I wanted to do the RCT. Vahid, I wanted to do an RCT on reverse fracture, like lateralization on the base plate versus not. Everybody says do Grimmont, so that way it allows you to get it to heal, but at the same time, like I wonder, I wonder because reverse fractures like aren't always like the best. I mean, some get good motion, but some obviously don't get perfect motion, and so I
Yeah.
wonder. I wonder if we can get away with at least some lateralization. So I was trying to convince Gottschalk to do that study. We haven't done it yet, but
I think Pat Denard, like, maybe had a paper on like that lateralization. I mean, again, it's relative how much, but like, uh Grammont versus like a modern design, it showed that the GT healing didn't matter, maybe like reverse because it's a constrained implant. The GT healing is so predictable that maybe the lateralization is less of a factor. But I'm in the same boat is that I don't want them to impinge, and sometimes like the GTs that you heal repair, not all of them heal exactly where you put it. Like now you have these GTs is slightly closer to the glenosphere, and if you don't have lateralization, I feel like that can work as an impingement, and their range of motion will be poor or will be a source of instability, a non-union or malunion of the GT. So. I definitely I'm with you is that you kind of like grapple with this idea of like I don't want to over lateralize because the GTs will be under tension, but also I don't want to like create this kind of tucked in GT to the base plate that will create like more. I have I'll be honest with you, I haven't changed my glenoid side treatment, meaning that I will still do a +3 and a +3 gluteus plate. Like I'm trying to stay within that like, 5 because you end up reaming a little bit. And so the overall construct is within that 5, 6 millimeters, but I'm not going more medial than that. And I would say in a moderate size to large size patients, you don't have any problem. The problem I have is that, if the patient is a slightly smaller size, I feel like that 5 millimeter is even too much.
Yeah.
So in the smaller females, I'm just not lateralizing through the glenosphere, and I keep that in the future in case like, that patient had instability. So I'll do a +3 to the base plate and nothing on the glenosphere side. That has been overall my approach of like if you're 5'5" or 5'4" and bigger, I'm doing 6 millimeter for fracture through the glenosphere. And if you're smaller, I'm doing like, that 3. So, but it is a good question, and I agree. Fracture stem is like has a totally different feel. I changed to retentive poly since I heard that this is actually the retentive of this system is actually close to the standard of other polys. I have switched across the board to retentive, and I'm like Mike, like maybe every 6 months there's like a really tight patient that I end up doing a non-retentive patient poly. Um, but generally speaking, I'm using like the 55%. I really like the perform fracture stem because it saves you cementing a lot of patients. And I'll tell you, my main stem for fracture used to be Revive. First of all, it's expensive, but also I've had like, 4 or 5 Revives come back like a year or two later that are, they're loose, the screw spinning off, and I think um they're having problem. I have to like take 2 of my revives back. I mean, I did a lot of revive. Like revive was my main revision. So I've done like about 100 or so revive stems, and of those, like I have to revise maybe 5 of them because of complications. So, but I really like the fracture stem. Perform fracture stem has become my like revision light kind of stem.
And
It's
you said
monoflow,
you said you've gone retentive on the poly or not really?
retentive across the board. Yes.
Even on for fracture. Interesting.
Yes.
And for your females, are you just putting in a 36 standard essentially every time for most women?
So I
No, he
follow
just said, Gotcha. He
trainers
said
like you.
he's doing three. He does similar to what I do. He does three for people 5'4" and over. There's three on the base plate, +3 on the base plate. And he does +3 on the base plate, +3 on the glenosphere for people over 5'5".
And if somebody is like less than 5, I'm doing 33, which is already 3 plus, and I'm doing a base plate that's not lateralized. So kind of like you really go small and really small patients, 4'8", 4'9". I mean, those are out there, but um,
So interestingly, that's actually why. So the main reason I used the perform Vish, I don't know if you were there. I think it was Eric that was there. The main reason I used the perform last week was because this person was under 5 feet, and that way I could use essentially a 33 on the glenoid side. Because otherwise, there's almost no way. I mean, she was so small. I was like, there's just
yeah.
no chance.
I agree. I mean, size, I actually looked up 120 of my patients and kind of tried to correlate based on their height and the glenosphere size. And there's like a clear, like linear correlation between height and what glenosphere actually I ended up putting in folks. So I tried like 33 is like 5'2" and below, like 36 is 5'2" to 5'5". 5'5" to 5'8", 9 is 39, and anything above 5'10" is 42 for me. So it's a little bit of a kind of like I know some people say I will use 36 and 39 and don't variate that much. But I think, what we don't talk a lot, I try to kind of allude into my talk is that when you go bigger glenosphere size, the space on top of the glenosphere gets really limited. Like I range them, and at times you need a +3 poly, and now you have a 39 and a +3 poly, and the patient's abducting, and that humerus is like, almost 4 or 5 millimeters above the top of the glenosphere, and really, I think those are the ones that the acromion can break the GT can break the acromion. It kind of cracks, in abduction.
Yeah. Oh, that's awesome. All right.
Yeah, this was
Well,
great. I gotta tell you, very appreciative to hear all your insights and everything.
Of course, it's great talking to you guys. Like, we have a little bit of kind of every center have a little bit of an echo chamber. We keep talking about ourselves. Like, I really like these kind of exchanges because we kind of get it out of our shell and hear, different thought processes. I really enjoy talking to you guys. I didn't get the chance to talk to Joanne and Michelle to see if they have any questions.
Thank you so much, Dr. Entezari, for a fantastic talk. I know we're running late, but I just had a quick question. Do you ever send patients for bone optimization? For example, any bone health medication before surgery if they have poor bone quality on, say, Hounsfield units on their CT?
It's a very good question. I don't do it systematically, but there are a few times, like, last year I delayed two patients, like, reverses, because first of all, they weren't like, that urgent, and we were anyway going to kind of wait for 6 months. And I was seeing this kind of washed out bone on their x-ray and bring up the conversation of like, have you had like any hip fracture, any distal radius? One of them had a distal radius like, plated, and the other one had a nail of the humerus, and we were going to kind of wait for like 4 or 5 months. And I'm like, how about we get a bone mineral density and I get you see one of my bone health specialists. Both of them were placed on one on Fosamax, the other one was Prolia because she had treatment. I don't know if it changes their risk of like acromial fracture. At times we're in this kind of mode of like people come and want to have their reverses in a week or two. So it's kind of like doesn't lend that approach itself to a lot of patients that have ton of pain and their surgeries have a little bit of acuity. But to your point, we should include more of these type of like optimizations in our like if a patient now I ask patient to get off their chair and go to the door and come back as we were talking about reverse, and I kind of do it conversation. I want to like like see how you're like it will be you will be amazed. Some of them have like difficulty getting off because when you enter the room, they've already been situated in the you know chair. They're facing you. They have so many ways of fooling you. But then like you ask them to get out of the chair, they're like doing this and they're just like pushing themselves. They can't get like more than one or two steps. I That has been like, my kind of quick test of saying like, hey, maybe, we just hold off. I'll send you to physical therapy. Let me have them assess you. And it's easier in my system because my hip and knee guys are doing it. They won't do a hip like, replacement unless somebody sees like physical therapy sees them before surgery. And I've what kind of used the same therapist. So if I see a little bit of like mobility issues, I'll send them to therapists and they kind of go over, their home situation, their like assistive device and all of that. So yeah, part of me is like, I would rather do like, five less reverses, but have five less complications, like, a year. And because some of these periprosthetics, some of these like, they're actually they change people's like, uh outlook in life, and they're not benign.
for sure.
Very good question.
Yeah, it's actually pretty
We get to
easy.
ask one more question.
I was
Go
gonna say it's actually pretty easy at Atlanta because if you get a complication or something, you just send it to Wagner.
ahead. I
I'm
I'm
joking.
Cleveland's
Truthfully, it's
Wagner
actually
too, so I think we get like I get all the
I'm actually joking because typically what happens is it actually comes to either him or me, but it's always one of the two of us. It's not. I wish I could say it's super easy when everyone just says like, oh, just send it to Gottschalk, send it to Wagner, they'll take care of it, and that's normally what happens.
Unfortunately, it is true, but it's all right. You get that too, Heath. I'm sure.
One of my tumor partners always say, I really want to see the day that I can rotate off of my own service. So you kind of lose that as a trainee. It's like, yeah, tumor sucked, but I have to like, wait for another week. I'll rotate.
Yeah, no kidding.
I joke with that. I said that all the time. I said the difference between being a fellow and an attending is that your patients don't leave you, right?
That's true. Your decisions becomes like, oh, I made that decision. You never forget the decisions you make. It's like, I made that decision and I lived by all that came after that.
So that's a valid point. I tell all of our trainees, the mistakes that get you are actually not typically the ones in the OR. It's actually the ones in clinic where you said yes and you're taking the patient to the OR and you've pre-decided what you're going to do. And it's when you're in the operating room that you got yourself into trouble because you probably should have never been there in the first place, or you chose the wrong idea of what you should be doing.
Yeah. Dr. Ainati used to say, like, we would like evaluate, like, we still have like this revision kind of journal club, like, we'll kind of sit around and talk about these disaster plasties. And he would start by saying, every surgery except the first one was indicated. The first one could have avoided all the other ones.
Unfortunately, it's so true. It's so true. Well, Reed, thank you so much, and thanks for spending extra time with us. I think this might be a record for as long as we've gone, so I appreciate you engaging. It's always really fun. Um, yeah, man, and really appreciate all the insight. Like I said, that was absolutely fantastic. You clearly have given this so much thought. It's really good, really cool. It's exciting too, honestly. Like when you look at all that, we look at the potential, look at all the data that we have, and where we're going with this. It's really exciting. So
Absolutely. I enjoyed it too, as well. Get to know Eric. I knew you, but like, I've never interacted with Mike and Joanne and Michelle, so this is great. Thanks for inviting me.
yeah, of course, man. Well, one of these days maybe we'll actually get you down here. That would be even funner. So or more fun. So and then you'll really get to kind of hang out and get to know Lana a little bit. So,
I'll
but
love it.
in the meantime, thanks again for joining us.